So shall we get started?
Let's get started.
Okay.
You're starting, right, Teresa?
Yeah.
Okay.
Good evening. I'm Teresa Watanabe, AAJA-LA Vice President for Special Projects. I apologize for the confusion, but I do want to thank all of you for joining us for tonight's session. It's co-sponsored by AAJA chapters in Los Angeles, Sacramento, San Diego, and San Francisco, and generously supported by the California Endowment. I can't thank our partners enough. And a huge thanks to tonight's participants, especially our moderator, Usha Lee McFarland, who will tell you about our distinguished guests. We hope to have a lively conversation about this most important topic of health disparities in Asian Americans, Native Hawaiians, and Pacific Islanders. So please use the Q&A function to ask your excellent questions. Next slide, please. Before we launch into our program, let's also take a moment to contemplate a little history and to be grateful for the toil of those who came before us. The effort to reject derisive terms like Oriental and create our own identity isn't unique to those of us who are of Asian descent. Other pioneers have created identities and built histories for communities of color, notably African American and Black civil rights activists in the 60s, and our allies broadly described as Latino, Hispanic, or Latinx. And we've also seen how naming a people can go wrong, descending into ugly name calling and divisiveness. Next slide, please. But most of you who join us today may just reflexively recognize that we Americans of Asian descent embrace the descriptor of ourselves as Asian Americans. This was not a natural fit, as author and journalist Jeff Yang has observed. Next slide, please. The very term Asian American is relatively new, created by two 60s pioneers during the tumult of the Civil Rights era. Next slide, please. As the late Yuji Ichioka observed, it was vital for the many smaller groups to present a unified front for them to gain recognition and advocate for their important causes. Next slide, please. But those who coined and made common the Asian American description could not have anticipated how it would be stretched. As U.S. foreign entanglements increased and society became at least a little more progressive, immigration laws shifted drastically. The numbers of people of Asian descent began to grow in the 60s, 70s, and 80s. Next slide, please. But even as our numbers grew, Asian Americans had to battle to achieve prominence and political power. We can see this, and one of our guests today can tell us more about this, by looking at the legislature in the nation's most Asian state, California. For decades, representation in Sacramento was spare at best. By 2001, the Asian American numbers rose enough to persuade lawmakers to launch a political caucus. Today, the California Asian American and Pacific Islander Caucus includes 9 state lawmakers, which underrepresents the proportion of AAPIs in the state. By the way, this also is mirrored in Washington and Congress. Next slide, please. And the public has a limited understanding of who Asian Americans are, demanding much more nuanced, careful thinking. The US Census and demographers identified 21 different ethnic groups within the Asian American umbrella. And the term AANHPI is even more complex because it incorporates even more and varied people from Hawaii and other isles of the Pacific. Next slide, please. Various factors differentiate us. For example, our median household income. Not all Asian Americans from the subcontinent are wealthy, but the disparity is striking between the $158,521 median household income for Asian Indians versus the $37,372,000 for Bhutanese. Next slide, please. Those groups that have immigrated more recently to this country are disproportionately burdened by poverty, while individuals and groups that have longer time spans in the country fare better. Next slide, please. The divides in the Asian American community also can be stark, with differences in language proficiency and isolation, household income, poverty, education, occupation. Our experts will discuss these so-called social determinants and how they affect Asian Americans' health and well-being. They'll also discuss the importance of disaggregating data, separating out various AA and HPI communities to develop effective, pertinent policies. Next slide, please. We also can't ignore what the coronavirus pandemic and hateful racism have reminded people of Asian descent all too well. We may be different as individuals and as different communities, yet too many people in America see us indistinguishable, interchangeable, and as the other. Next slide, please. We have many differences, but we also have much in common. The question tonight is, how do our AA and HPI identities and perceptions or misperceptions of them affect our health, proper recognition of our needs, and disparities in quality care? And so without further delay, it is my pleasure to introduce Usha, a Pulitzer Prize-winning senior correspondent with the fabulous science and medical news site, STAT. She has done a marvelous job in putting together this and other programs for AAJA, and she will tell you all about our great guests. So take it away, Usha.
Okay, thank you, Teresa, and thanks everyone. And congratulations to people who have made it into the webinar, which we made very difficult to find. So we appreciate you, and we are recording this for everyone else, so everyone will get a chance to see it. I am just thrilled to present this panel. We have Dr. Stella Yee, a cardiovascular epidemiologist from NYU Grossman School of Medicine, who researches health disparities in Asian American and immigrant populations. We have Ms. Monica Lee, Associate Communications Director for the California Pan-Ethnic Health Network, Multicultural Health Advocacy Organization. And we have Dr. Richard Pan, California State Senator and pediatrician. I've heard Dr. Yee speak about her research. I've heard Ms. Lee speak at journalism conventions, and I've interviewed Dr. Pan for Medscape, though he may not remember. They are all deeply thoughtful and such great speakers. So I don't want to take up any more time. I'd like to introduce Dr. Yee, who is going to share some of her insights from her work.
Hi, everyone. Good evening. It's nice to be here. It is 9:30 in New York City, and I usually when I go to sleep right after my 3 and 5-year-old, but I'm so happy to be here, and I hope you find this interesting and helpful. Okay, so I wanted to start out our discussion today by sharing an anecdote that illustrates some of the issues that we're going to dive into for the next 15 minutes or so. This is national data that was collected during the COVID-19 pandemic from the Census Pulse survey, showing food insufficiency rates by race, ethnicity. And what are some of the first things that we notice when we look at this graph? So number one, Native Hawaiians, Pacific Islanders, American Indians, and Alaska Native communities are not even on this graph. And number two, we notice also that Asian Americans have the lowest food insufficiency rates in the United States. So why is this interesting? I would like for you to contrast that data with data that we have collected in partnership with 27 community-based organizations among Asian American New Yorkers in 2021. And in this data, we found that accessing food was the #1 challenge during the pandemic for Asian American New Yorkers, with 51% of respondents indicating this need, and this need varied by Asian American ethnic group. There are a few differences in survey methods and approach, but the major difference between these two survey efforts was the languages they were administered in. The national data is collected in English and Spanish only. In contrast, in our data, over half of respondents took our survey in an Asian language. And the unintended consequence of conducting surveys in only these languages, English and Spanish, is overrepresentation of Asian Americans with higher education and income levels, who tend to have better social and health outcomes. And you can see clearly that once data was collected in language, the gaping disparity in food access was revealed. Thus, when data collection in Asian American communities is done only in English, social needs stay invisible. I want to expand more on the data equity piece a bit more. We assert that poor quality race ethnicity data is a form of systemic racism. It's easier to unpack this statement using real data. So here I'm showing national COVID data from the CDC. As of yesterday, October 26th, data on race ethnicity was missing for 35% of cases, 15% of deaths, and 22% of vaccination. Now, the problem with this is that the people that are probably making up this missing group are more likely to be one of these racial ethnic minority groups. And while we don't know this precisely about the CDC data yet, we know this to be true from prior research on other large hospital systems, state and federal data, including Medicare. The second factor is the problem of data aggregation. This affects not only these groups listed here, but also has been documented to be particularly problematic for Caribbean versus African Blacks, Middle Eastern, North African, or Arab American communities, and for non-US born white communities. And this problem of missing race ethnicity data is more common than you think. Here is another example from a large administrative data set showing the breakdown of race. Overall, over 40% of the people in this data set have missing race ethnicity values. Again, in both of these examples, those who are missing are probably those from racial ethnic minority groups. To put this in another and more visual way, in this country, we are essentially making critical decisions about funding to communities, policies, and resource allocation based on data that represents only a proportion of the US population. And further, the proportion not represented are racial ethnic minority communities and those who are limited English proficient, who are more likely to face socioeconomic related challenges and have poorer health outcomes. This erasure is systematic, it's classist, and it's racist. So what are some of the health disparities in Asian American and Native Hawaiian Pacific Islander populations? Here's a slide depicting the top 10 leading causes of death for Asian American or Pacific Islander adults. Unlike the total US adult population, the leading cause of death for this group in aggregate is cancer. But when these data are disaggregated, interesting disparities emerge. For example, heart disease was the leading cause of death for Asian Indian women and men, Filipino men, and Japanese men, not cancer. Research and interventions for these groups can then focus more on heart disease rather than cancer. In terms of understanding the landscape of health disparities amongst Asian American and Native Hawaiian and Pacific Islander communities, I wanted to share also our Health Atlas, which is a comprehensive data effort across 2 national, 5 state level, and 3 city level data sets, reporting prevalence estimates for 22 health behaviors and risk factors reported at the smallest ethnic group available for Asian American, Native Hawaiian, and Pacific Islander groups. This effort took 4 years to develop with our expert community and scientific committees, and is now available on our web hub. So here are some of the main findings, slightly overwhelming, wordy slide, but I'm not going to go into detail about it, but I do encourage you to skim, and also feel free to reach out to us if you have any particular data needs or disparity questions for different regions or Asian ethnic groups. Another resource that is helpful to understand the health landscape is a wonderful effort led by our colleagues out at UCSF, which was an NIH workshop, or National Institutes of Health workshop, convening experts on Asian American, Native Hawaiian, and Pacific Islander health from across the country to enumerate the gaps and opportunities for research in these groups. A heat map from their efforts highlights the major gaps in knowledge for cardiovascular disease, cancer, and for specific ethnic groups. Focusing in on the lightest blue and gray areas can give you a sense of where gaps are. So for example, more research is needed for Vietnamese and Korean communities for cardiovascular disease, and for Native Hawaiian and Pacific Islander communities for cancer. And this workshop was in part a response to the established fact that Asian American and Native Hawaiian and Pacific Islander communities are the most understudied racial ethnic minority group in health research. Only 0.17% of the total NIH budget funded research studies focused on the Asian American and Native Hawaiian and Pacific Islander populations from 1992 to 2018. And given the overall percent of the US population of approximately 6%, you would expect for this percentage to be on par with 6%, but it's clearly not. And we conjecture that this is in part due to the model minority and healthy immigrant stereotypes that are often applied to Asian communities, Asian American communities. So I wanted to spend the next few minutes walking you through a few real-world examples of how we experience this interaction of data, issues, and stereotypes in our day-to-day research. This is a paper that was published in JAMA Network Open, examining racial ethnic disparities in preterm birth infants in the US. And when you get to the graph stratified by race ethnicity, you see Blacks, Hispanics, and whites, but no Asian Americans. In the method, they include this sentence: mothers with more than one race, so you can't be multiracial, unknown race ethnicity, or race ethnicity other than Black, white, or Hispanic were not included. So there's no reason given, just that they were excluded. And this is from a data set, the National Health Interview Survey, that actually made the efforts to oversample Asian Americans starting in 2006. It's simply not good enough anymore to say the sample size is too small. It happens in one paper, it happens in two papers, and expand this all the way up to 100,000 papers. And the net product is that Asian Americans and their health experiences are invisible. Here's another example from the American Journal of Public Health, one of the leading public health journals. The authors were interested in the effect of Obamacare on health insurance coverage. And similarly, when you look at the main findings stratified by race, ethnicity, and this graph shows uninsurance going down with Obamacare, you can see whites, Blacks, and Hispanics, but no Asians. And this was using census data. The authors did provide a reason for why they did not include Asian Americans in their analysis. We focused on whites, Blacks, and Hispanics in line with much of the literature on health disparities. Here's another example from a paper published in May of 2021, where the investigators examined stress and burnout among US healthcare workers during the COVID-19 pandemic. So we can take a look and see what this study, what this database was that they looked at. So they looked at the US Coping with COVID study. It looks like in their sample, there was about 21,000 healthcare workers, 14,000 were white, about 1,200 were Latinx, 1,200 were Asian, Pacific Islander, and 1,200 were Black. Okay, so what were some of the results of this? Here's a snippet from table 2, race ethnicity. We have the white, the results for the white participants, the results for the Latinx Hispanic participants. Then we have a white Latinx comparison, and then we have a Black, the Black participant information, and then a white Black comparison, and that's it. And so you're like, okay, what happened to the other racial ethnic groups that were in this cohort? Okay, oh, that's funny. There is this little footnote here. Let me go check out that footnote. Other races, Native American, Asian, other, and prefer not to answer, not included. So as you all observed before, the sample size for Asian was the same, if not bigger, than for Blacks and Hispanics. All this while Asian American and Pacific Islanders are overrepresented as healthcare essential workers. And in some states like Hawaii are 72% of all healthcare workers. Here's a slightly different example. There was a new report released in July of 2021, prepared by PolicyLink. Racial equity is the main point behind this 115-page report. They included this interesting statistic. There is a 50 times higher likelihood for white and Asian researchers to receive grants compared to Black researchers. And they cite this report / infographic on racial disparities in funding at the NIH website, which inexplicably lumps white and Asian together. And it appears that somebody divided the 8,368 by the 166 funded grants in 2020 to get this 50 times statistic. This report, in turn, cites Ginther et al. From 2011, where the original finding was that Asians and Blacks were actually less likely to receive investigator-initiated research funding compared to whites. So why? In this case, it's sloppy work, but I'd also argue implicit bias about Asian Americans and the model minority stereotype. These last two examples are from my own research. So this was an analysis that we did looking at physical activity levels in New York City and in Los Angeles County. And it's an interesting question because they're cities with two very different geographies in terms of layout. So Los Angeles is a horizontal city, more of a driving culture, whereas New York City is a vertical city, and there's a lot of active transportation. And then seasonally, it's feasible to be outside and exercising all year round in Los Angeles County, whereas in New York City, the season very much dictates whether or not you want to be outside. So anyway, we found and looked at different race ethnicity disparities within meeting physical activity guidelines. And we found that Asian Americans were the least likely to meet physical activity guidelines. And when I would present this data at scientific conferences, the reaction that I would get was this: but what about all those people doing Tai Chi in the park? And so the point of this example is that when people's impressions and data are incongruent, you will be met with skepticism. Here's another example. This was an analysis that we did looking at national data, and we found that Asian Americans have the highest sodium intakes across different racial ethnic groups. And when I would present this data at conferences, the reaction I would get would be, oh, it's all the soy sauce. And so again, in this example, when people's impressions and data are congruent, you will have buy-in. So I just wanted to close this section with very brief mention of confirmation bias. And confirmation bias is the tendency for people to embrace information that supports their beliefs and rejects information that contradicts it. And this is what is the hardest to tackle within our work, to try to undo the beliefs that all of us hold about the Asian American community. I'll just finish up with some of the work we are doing to combat these complex issues around data equity, food access, and racial stereotypes. First, we are working with New York State to support data disaggregation efforts, not just for Asian American and Native Hawaiian and Pacific Islander communities, but for all racial ethnic groups with our IDEAL project. IDEAL follows decades of advocacy for the collection and reporting of disaggregated data for Asian Americans. In a historical win, our community partner, the Coalition for Asian American Children and Families, CACF, and our team at NYU Center for the Study of Asian American Health were awarded a contract by the New York State Governor's Office as a result of the Atlanta shooting to advise on best practices for the collection of specific ethnic group data at the New York State Department of Health. And we currently are assessing the state vaccination data as a test case. We are also working with NYU Langone Health leadership to implement a new way to capture more granular race ethnicity across the entire health system. Second is our BASIS project. BASIS is a partnered effort across 3 farm, 4 community-based organizations, and an elementary school that incorporates a culturally appropriate and subsidized fresh produce box that features Chinese vegetables, nutrition education, policy advocacy, experiential learning, and workforce development for the Chinese and Mexican American communities in Sunset Park, Brooklyn, an immigrant community that was hard hit during the pandemic and has been less connected to government relief programs. Lastly, we continue to produce data, disseminate, and try to educate folks about their potential internal biases about the Asian American and Native Hawaiian and Pacific Islander communities that then feed into their research, data, and reporting practices. So just some closing thoughts. Data infrastructure is critical to advancing health equity, but current data infrastructure systematically excludes racial ethnic minority groups and those who are limited English proficient. Efforts to modify data infrastructure should be multi-sector, multi-level, and collaborative to rebuild trust across all groups and should be conducted in multiple languages. In terms of what you can do, address your own potential implicit and explicit biases and educate about these harmful stereotypes and data issues. Don't perpetuate. And improving the narrative is messy and complex, but it's not impossible. Oops. Just my acknowledgement slides. So thank you and look forward to the discussion.
Thank you so much, Dr. Yee, and thank you for staying up with us. We really appreciate it. And welcome to attendees who made it through the gauntlet to arrive here. Next, I would like to, well, first of all, that was an incredible presentation. I see people on the screen and I could see them just kind of shaking their heads. There's nothing like putting numbers to something that's largely invisible. So you made it visible. I think that is amazing. Next, I'd like to introduce Ms. Monica Lee from the California Pan Ethnic Health Network, who'll discuss some of the work she's been doing with California Asian communities.
Thank you. And I will, let's see, I'll share my screen. Okay, great. Yeah, well, good evening, everybody. As you just said, I'm Monica Lee. I'm the Associate Communications Director with the California Pan Ethnic Health Network, and we focus on addressing health inequities and racial injustice. So a little bit about the organization that I work for. We came together in 1992 after the beating of Rodney King and the subsequent acquittal of the police officers involved. Four of our founding organizations recognized that we needed to bridge the divisions and unite our voices to advocate for just, equitable, and a healthier world. And so leaders from the Asian Pacific Islander American Health Forum, California Black Health Network, California Rural Indian Health Board, and Latino Coalition for Healthy California came together and founded CPEN, acknowledging that we are stronger together when we are fighting inequities and fighting systemic racism. And so we do our work in a variety of ways, one of which is bringing communities of color together in various networks to empower them and build their own power. And so we do trainings on the legislative cycle, we do storytelling and narrative trainings, and then we also advance policy and policy agendas, which include disaggregating data, culturally and linguistically competent care, and things like that. We then pass and implement those policies, which I'll talk a little bit about. We invest in communities of color, so we do sub-grants to many of our communities so that they can do the work that they do at the local level. And we connect data, stories, partners, and regions together. So our over 50 partners come from across all of California in rural areas and major areas as well. And we do all of this in hoping to create equitable conditions that promote health equity so that there are no barriers and systemic inequities to people's health outcomes. So some examples of our work. So this year we attempted to pass SB 1033 by Senator and Dr. Pan, who was with us. It would have established a statewide standard for demographic data collection among private insurers and health plans. Despite appetite, the bill was held due to cost concerns, and so we're still in talks about how we might, revive or bring this back. But in a win in 2016, we were able to pass AB 1726, which required the State Department of Public Health to use additional and separate collection categories and other tabulations for specified Asian groups and Pacific Islander groups. to talk a little bit about our work in cultural and linguistic competency. So making sure that people who are receiving care in a variety of ways are doing so in language and in a way that is culturally appropriate. And so in 2014, we passed AB 505, which required departments and all managed care plans contracting with departments to provide Medi-Cal services, to provide language assistance services, which includes oral interpretation and translation services to limited English proficient Medi-Cal beneficiaries. We also last year in the California state budget passed community review of Medi-Cal documents. And so Medi-Cals, are often low income or also undocumented individuals. And many of the forms that the state was sending were not properly translated, were done by a mass conglomerate company. And so we actually secured funding in the state budget to contract with community-based organizations to review documents and provide edits and changes so that they were more appropriate. We worked also with co-sponsors on the Health for All push, which is ensuring that everybody, regardless of age and documentation status, can access Medi-Cal. And we are always researching disparities in oral and mental health outcomes, the second of which I will speak a little bit more on mental health specifically for Asian American, Pacific Islanders, and Native Hawaiians. So a large part of the work that I do as an associate communication director is framing of these issues, and something that Dr. Yee mentioned, right, is kind of changing the narrative, the dominant narrative that we see in a lot of mainstream news, or, along with journalists, scientists, everybody is sort of a part of this. And so, Asian Pacific Islanders, as Dr. Yu mentioned, we're over 50 ethnic groups in over 100 languages. We're the fastest growing population in the United States. And so this issue of data and the need for data disaggregation and just how our communities have been invisibilized. And so I pulled a couple quotes that I thought really framed the message well. So if you don't have the data that shows your community is in need, then when the funds come that could help, they don't come to you, and that is a form of racism. And then secondly, this issue of lumping all AAPIs together does make it harder to get funding, to collect better data and develop effective interventions. And this person calls it the gaslighting of the Asian American population that's been going on for decades. It's an example of anti-Asian structural racism. And so it's sort of this perpetual cycle, right? If that we, can't address what we can't see, and then it continues with no funding, divestment of resources, and these continued poor health outcomes for people who we know are marginalized and in need. So I do want to highlight two community-based organizations that we've done work with. So through the California Reducing Disparities Project, which here in California uses Mental Health Services Act funds, specifically for community-defined evidence-based programs. And so I think a lot of times when people think evidence-based, they think, oh, it's been, rigorously tested and proven. And we really wanted to show that there are interventions that community-based organizations have been using for decades that work, but that are not seen as such because they don't adhere to, white or Western norms. And so one group is the Hmong Helping Hands intervention. And so this is based in Fresno, Merced, and Stockton, and they focus, sorry, I think my PowerPoint quit on me. But anyway, working with these groups and really the specific communities they serve. Okay, we're back up. All sorts of the technical difficulties today. Okay. Okay, so as you can see, there's roughly 280,000 Hmong individuals living in the United States, many of which were refugees. And so to try to improve adults and older adults' physical and psychological and spiritual well-being, their sense of belonging, the Hmong Helping Hands intervention brought people together to do a variety of cultural crafts, activities together in healing and in space. And they really found that folks really really enjoyed these sorts of interventions that really acknowledge their own history, their own language, and their own culture. And so this was really important and something that is still ongoing as we look at the outcomes to really tackle depression, anxiety, issues of, feeling like they belong here, and helping people really connect their sense of healing and belonging with their culture. The second community-based organization that I wanted to highlight is the Community Wellness Program with the Cambodian Association of America. And so similarly, Cambodian immigrants and refugees, escaped really traumatizing war and were left very traumatized by those experiences. And so under the California Reducing Disparities Project, we worked with them and they created this workshops to bring together, to bring together, Cambodians in search of that mental health and well-being, and the importance of spirituality and activities, including water blessings, visits to temples and churches, and meditation, as well as the arts and crafts, gardening, walking groups, and other things that can really improve one's own mental health and well-being. And so we're very proud to have worked with these organizations, gotten them funding to say, these are proven interventions to help improve certain populations' mental health and well-being, and that they should be valued and recognized just as other, Western interventions are, and that they're important from, a racial ethnic standpoint. So those are, a few of the organizations that we've worked with, and I think really showcasing the need for more acknowledgement, funding, and resources for these community-based organizations that do this really important on the ground and local work. So thank you.
Thank you. That is just beautiful work. And I think as a journalist, those are just incredibly important stories to tell about those communities and the connections you're making. Thank you. Next, I'd like to bring on Dr. Richard Pan to speak about some of the work he's done as part of the AAPI caucus. And it's interesting to me, the idea that maybe some of these problems can be solved with legislation as opposed to naturally, I guess, researchers or hospitals doing the work themselves. So love to hear your insights.
All right, well, thank you so very much, Aisha. And again, it's a real privilege to be here with all of you. And again, I also want to thank the AAJA chapters here in California. I know many Asian American journalists have bravely spoken up. We did a hearing on sort of the glass ceiling, which includes journalism, where many Asian Americans who want to try to share their stories have been stymied because the producers or editors or so forth said were less interested, and but they've still soldiered on. So thank you all for all of you who have spoken out and continue to try to get our stories out in the media. And it's certainly a real privilege to be here with Dr. Yi and Ms. Lee and the amazing presentations both of them gave. So I guess I'm going to give a little more of a political lens as chair of the AAPI Legislative Caucus, but I am a physician and I previously was a faculty member at UC Davis. So I'm part of sort of the academic medical world, and many of the things that Dr. Yi talked about were things that I have observed. So I thank you so much, Dr. Yi, for doing the research and getting the actual data out there. But I would make note that, for example, I saw the slide showing that it was less than 20%, 0.2%, less than 0.2% of funding RO1 were targeted towards studying the AAPI population. That seems to be in line with the fact that about 0.2% of foundation funding in the United States is actually directed toward AAPI communities. So even though we're 6% of the national population, a little over 6%, certainly even larger in California, funding is not going to our communities, whether for philanthropy or for research or many other areas. And we are not only underrepresented, we're underfunded. But the minority myth makes people think that everything's fine with the Asian American community and that we don't, quote, need help, unquote. The other thing I'd also make note is, again, I appreciate the presentation, how we just disappear in research, because as a faculty member who would go to academic meetings and over and over again. It said, where are the Asian Americans, Native Hawaiians, Pacific Islanders? And I do want to just acknowledge that the Native Hawaiian Pacific Islanders sometimes get buried in the API umbrella term too. So I want to acknowledge that. The same time, I'd ask that question over and over again at meetings, and I'd get these funny looks from the researchers, and they say, "Well, we don't quote have enough numbers," but that's not always the case. I mean, I'm in California. We're the third largest racial ethnic group, so it's hard to imagine why you wouldn't have the numbers, so that's a challenge. I would also make note, just to point out, in the the academic medicine world, in terms of disappearing. So the American Association of Medical Colleges, which is the sort of the association of medical schools in the United States, they don't break out when they talk about leadership, right? Who the deans and the racial ethnic breakup, we're lumped in with whites there too. Now, if you actually look through all the list of all the medical school deans, you start to realize that, even though we're 6% of the population in the United States and there's 150 some odd accredited medical schools, I think I found 2 who are probably Asian. Okay. All right. But we're lumped in with white. And so it's like, and so they won't report us out. The fact that we are woefully underrepresented, even though we're 20% of the faculty. So we're, quote, overrepresented. Again, that's without disaggregating. So we know that the various Asian subgroups aren't equally represented in the faculty. It's more concentrated in a handful of Asian subgroups who are, and I emphasize Asian subgroups because the Native Hawaiian Pacific Islanders certainly aren't underrepresented in medical school faculty, but they won't break it out and say, well, look, that glass ceiling. And we know that that's also true in many other fields as well. In fact, Asian Americans, while we may do better on sort of these entry-level professional positions, again, certain subgroups, whether it's physicians, lawyers, tech company, engineers, so forth, we have the lowest of all racial ethnic subgroups of the lowest promotion rates. So you get in the ground floor, your likelihood of getting promoted is lower than any other racial ethnic subgroup, the lowest. All right, so actually, that's my argument for affirmative action, because I know that within our community there are some subgroups who are concerned about affirmative action, have actively opposed it. I have, as a legislator and throughout my career and as a physician, have advocated for affirmative action. I said, well, we can't talk about race when it comes to entry to colleges and medical schools and so forth. How can we talk about the fact that we're being discriminated against when it comes to our advancement in our careers? So great, your kids can get in college, they can even get to Harvard, and then they get to start off at a career and they will stay there. And by the way, that's an issue. The disaggregation is so very important. I want to thank CPEN for your leadership on that. We were able to pass a bill authored by now Attorney General Rob Bonta. Previously, he was Assembly member. But I would also make note that as that bill was going through, and even though we were eventually successful, we actually had opposition within our own community to that bill because they were concerned having disaggregated data would lead to greater discrimination against API or their particular subgroup. Right. And so I think that it's politically, it's a bit of a challenge because we had, frankly, conservative Chinese groups come out and mobilize against disaggregation data bills. And so actually that original bill was actually supposed to be health and education. The education part had to be taken out because of that opposition. And we were able to finally get the health part through and get it signed into law. So I'd make note that while certainly disaggregation is really important from a political standpoint, there's actually opposition to that, and that's something we have to figure out how to navigate. Now, when COVID hit, and we saw again the rise in hate against Asian American, Native Hawaiian, Pacific Islanders, because even though we all come from different parts of and so forth, that we get lumped together here. So I think there's a saying, and I know, Dr. Yi, really appreciate you talking about this, but there's a saying that you become Asian when you come to the United States, right? You're not Asian back, when your family came from Asia, you become Asian when you're here, right? And so whether you want to identify as Asian American or not, the rest of the community will. So, you can tell someone, I'm not Chinese, I didn't bring COVID over, and they will still come after you. Okay. So it's, and by the way, you can say, I'm not Muslim, although we should never target Chinese or Muslims, for after 9/11, they still went after Sikhs, right, et cetera. So, I mean, when you're in this country, whether you want to or not, you're part of the group. So I just got to point that out. Reminder for everyone. And so the challenge is that, as we were looking at the rise in anti-Asian hate and the horrible events that happened across the country, but including in Atlanta, fortunately, we were able to. There's certainly a rise in interest in the issues facing Asian Americans. We saw that philanthropic contributions suddenly spiked from 0.2 percent to something a bit larger. We were actually able, as chair of the API Legislative Caucus, to pass the API equity budget, and where we were able to get $165 million to $65.5 million for over 3 years to address API issues. And in fact, because of the invisibility issue, so most of the money it was to go to support essentially survivors of hate incidents, to provide support to the community, like and to support AAPI community organizations who are doing that work. We did put a piece of it to invest it into research, and actually it got directed to AAPI data at UC Riverside to try to build research capacity in studying our community, because as was pointed out, without data, people say there isn't a problem. They said, well, we have a problem in our community. People say, show us the data. Well, sorry, people aren't doing the research, right? And including, of course, as I think what Dr. Yi pointed out, is that we need to be sure that people don't speak English as their primary language or comfortable, actually are included in the data sets and are included in the data collection. So we have to build that language capacity as well. And so that's something that we wanted to invest in, because it's important we get that information. I would make note that as I was looking at the COVID data coming out from the state here in California, because I chair the health committee, usually what happened is we did break out in California, Native Hawaiian Pacific Islanders, which, by the way, had the highest death rate of any group. Okay. So higher than Black, Latino, certainly not a race anyone's looking to win, but they had the highest. But then when you looked at the Asian numbers, the interesting thing is that, it looks like, oh, look, Asian Americans are doing all right. But again, I think it comes down what Dr. Yu so eloquently pointed out, and with her data is that if you look at just these racial ethnic classifications, looks like Asians do all right. If you actually break it out by primary language, which they speak, then suddenly like, oh, wow, look at all those people who speak Chinese and Japanese and Hmong and so forth. And look how high they're dying, look at their death rates. All right. So when you start looking at it from that lens, let's not call it racial ethnic, let's look at primary language. Suddenly it's like, oh, wow, all those Asian Americans are dying at really high rates, right? And because they probably weren't being collected, that information wasn't being collected accurately. So that is so very important that get filled in. Now, I would also make note that language access, so like this aggregated data, getting language access supported is politically very challenging. I remembered when we were rolling out the ACA in California, fully embraced the Affordable Care Act, and I went to Covered California, said, so what are you doing to outreach to AAPI groups? And particularly in language. They're fine when I said, how are you doing to reaching out to AAPI groups? Until I said, in language. Then they went, oh, well, we have stuff in English and Spanish. And I said, not good enough. And they said, but it's so expensive. You guys speak so many languages. Sorry, that was kind of a private conversation. And I said, well, too bad. Guess what? Yes, it may be more expensive, but you've got to do that, right? You have to do that. That's also why in California, I fought to invest literally, I think we put in $180 million in our census outreach for 2020 census. right? Because we have to put the resources behind that, and that includes in language. And yes, and I will also just share with you is that one of the things I've been working on, unfortunately unsuccessfully, this, is actually trying to get improved language access. And again, I want to recognize CPEN. Thank you so much for your leadership in getting, the documents translated, but actually access to language language access to actually getting your clinical care. So if you're on Medi-Cal and you go see a doctor or a nurse practitioner or a PA or whatever else, and to get someone to do interpreting, right? So I remember, and I partnered with Speaker John Perez. I mean, we're talking about the leaders in the legislature, and then Pro Tem Tony Atkins, who carried bills, and I would help advocate for them and speak on their behalf and so forth. And we'd even got a pilot project in Medi-Cal, and it was supposed to go from a pilot project, and somehow it seemed like the pilot project took, we finally got them to do a pilot project. It took forever. They never seemed to bring it to scale. So we're continuing to fight that battle. That's certainly a part of the root of the health disparity issue. Because there's just tremendous, I always just say there's just tremendous internal resistance to that. I can conjecture as to reason. Part of it's perhaps cost, but other reasons, and challenges. But it is a huge issue that we need to deal with when it comes to health disparities. Let's just step back and make note. A lot of times people think immigration is a Latino issue. Well, it's our community that's over half immigrants, right? And then we count people who are children of the immigrants. I think that's, that really skyrocket there. All right. And language access is critical for our community, yet it's been so difficult to get in every arena. It's a big fight to get it. And unfortunately, we haven't quite got there entirely. We certainly aren't there on the health front. So think about healthcare and not being able to understand. Your doctor can't understand what you're saying. You can't understand what your doctor's saying. And so it's great. We have a lot of API who are healthcare workers, but most of them, again, we have multiple languages. They don't speak all the languages. Many of them perhaps don't. So speak the language at proficiency that's needed for providing quality healthcare. And then, of course, and again, I really want to thank the previous presenters. The fact that we just are invisible, that our data is not collected. People don't know what the needs are in our community because there isn't the effort to actually collect that data. And so we need to address that. But we also have to acknowledge, unfortunately, there are also forces at work. It's not just merely negligence. There are actually forces at work who actually oppose those efforts. And we need to come together to overcome them as well. So with that, as I should point out that now that I'm elected office, I don't use slides anymore. Maybe when I go back to academia, I'll bring back the slides. But again, thank you so much for having me. I really look forward to the discussion. And again, I really want to thank all the journalists API journalists who are part of AAJA for your work. And hopefully we can help support you to get those stories out, and then tell us what we can do so you can get our stories out to everyone else. Thank you.
Thank you so much, for sharing. You touched on so many important things, and I can't help feeling how mutually reinforcing all of these issues are, that worsen each other and deepen them. Before we get in the discussion, you talked about lack of representation or lack of advancement in medicine. I will mention I wrote a story recently. Someone analyzed all the large prizes in biology and medicine, from the Nobel down to the Genetic Society of America medals. Very few were given to Asian American scientists. It was shocking. It was shocking given that, we think of Asian scientists in research labs everywhere. So I want to
thank you for writing that article. I've been sharing that with lots of people. I just shared it with another person just yesterday.
We can put it in the reading list. Shocking. We have a special guest I want to introduce right before the discussion. This is you talked about the lack of representation of Native Hawaiians and Pacific Islanders. This is Dr. Kakoa Tapara, who's graciously joined us, and he is possibly, we think, the only Native Hawaiian MD, PhD radiation oncologist. He's at Stanford, and he's done some amazing work on looking at cancer disparities. So I wanted him to share a little bit about that, and then we can start our conversation.
Yeah, mahalo, Wisha, for allowing me to be here today. I just want to clarify, first MD, PhD, Native Hawaiian, period. There are no other ones, according to Ahui Nakoko, which is our Native Hawaiian Physician Association. But I want to just introduce myself briefly. So again, my name is Kekoa. I am originally born and raised on Oahu, Hawaii. Both my mom and my dad are Indigenous Native Hawaiian. I actually attended Kamehameha Schools, which is a institution founded by one of our last princesses of our dying monarchy, Princess Bernice Porhi Bishop, who really founded the school on her deathbed, as 95% of our population became extinct after colonization and infectious diseases brought by foreigners into our land. And at the school, we really learned Hawaiian tradition, Hawaiian language, Hawaiian culture in the context of Westernization, so that Princess Pauhi really wanted us to thrive in this changing dynamic society as we became more colonized. And so I am a little bit about my background. I did undergrad in Connecticut, did my PhD at Hopkins, did medical school out at Mayo Clinic, and now I'm a radiation oncology resident here at Stanford. My path to medicine has been completely non-traditional. I actually wanted to be a dolphin trainer growing up. My mom, it's a public high school teacher in the pineapple fields of our town. And my dad worked as a mailman at our electric company power plant and worked his way up. But medicine was never something that I saw growing up. It's not something that is a part of our path and of our communities. My Kamehameha School classmates sang in Lilo and Stitch, and that's how they paid for college. Even Moana came from my school. So we oftentimes go into entertainment, into sports. I was a D1 swimmer, and that's the only way I got to college. So I really accidentally came to medicine and science and PhD just through great mentors. And a lot of my work now, published in JAMA, Lancet, JAMA Open, and many of the journals that we discussed tonight, really focuses on really the key differences between Asian American and Native Hawaiian and other Pacific Islanders. Like they're, and OMB, Office of Management and Budget, they're federally recognized two different racial categories since 1997 and must be disaggregated. And I totally understand. My work is further on disaggregating the monolithic Asian community as well. But any way you look at it, Pacific Islanders, particularly Native Hawaiian and other Pacific Islanders, are always going in the opposite direction. And that's something that I appreciate this space to kind of talk about it. I do want to emphasize the point when we say AANHPI, or even when we spell it out, really, I hope that people can be a little bit more intentional in how they're using the alphabet soup. Really, because if we aren't actually talking about the NHPI community and we're using the AANHPI, we're making the majority of the letters, yet we're actually not talking about. And that's okay. I think it's okay when we're talking about the Asian American community, not in the context of NHPI. And that's okay to leave them out, but really it contextualizes what we're talking about. So I really advocate for people to try and use the AA intentionally rather than just tacking on NHPI when the data actually doesn't apply to NHPI. Because a lot of my work, even when it comes to, for example, representation in United States in terms of medical school, yes, there's 3 times more representation compared to the census data for Asian Americans in medical schools, but it's only half of what we'd expect for Pacific Islanders. We are the least represented in US medical institutions. And even when it comes to COVID, we always talk about, AA, Asian American hate, and during the COVID pandemic, I don't know of any Pacific Islander who felt a lot of those things. So that's generalization in terms of our perspective, our attitudes, that we, can't be generalized to that. And we want to be allies for sure, but to say that we experience a lot of those things is just kind of putting words in our mouth, I would say. And so I definitely am really excited to be here, really appreciative to listen to all of this fantastic research in the space of data disaggregation, and hopefully I can provide my perspective as a Pacific Islander.
Wonderful. Thank you so much. I mean, I think that's a question. We're journalists. We know words are so important. I want to recognize one of our members we just lost to cancer a few weeks ago, Henry Furman, who was responsible single-handedly for getting Associated Press to remove the hyphen from Asian American. huge. And now, you're right, I think people are just tossing around AAPI, not even with NH in it, is like the new term, and it seems like, I think many people feel like it's an advance. So I would wonder, and I know Dr. Yee, you've talked about this, you know, I've heard some people say Native Hawaiian and Pacific Islander people should maybe are closer to Indigenous and should be included in that group because it's more, you know, closely aligned health-wise, and it would make that pool larger, so they might show up in pie charts or research. So I'm just wondering how you feel about that and what advice any of you would have for journalists as to how we might use the terms in our stories more intentionally and thoughtfully.
Yeah, I have a lot to say about this. I'll try to keep it brief though. So we have worked in very close partnership with the NH-NPI communities over the last 18 years, but really in close proximity during the COVID pandemic. And there's a lot of strength in being able to work together, but I agree that there is a lot of sloppiness when it comes to the use of the terms. And the fact that there's no agreed upon term across, you know, the White House is using one thing, and then there's AAPI Heritage Month, and then there's AAPI this, there's AA that. It's a mess. So in my practice, what I do, and I completely agree with Kakoa that, and this is the guidance that we've been given by our Native Hawaiian and Pacific Islander partners, is that it's AA/NH-NPI, but only, to Kakoa's point, if you are actually representing NH-NPI within your organization, within your data, within your research. If you just kind of throw that out as a blanket term just to be consistent, or just because you're not being thorough in who you're actually talking about, it gets confusing. You probably noticed even within my own presentation, sometimes it's Asian American, sometimes it's AA/NH-NPI, sometimes it's, you know, AAPI. And that's because the data that's available is a mess. There's no consistency. So I completely agree that there has to be intentionality about the way that you use the term. I'll read like multiple papers, multiple like newspaper articles, journal articles that where people are talking about API, and there's no PI. It's like literally, or it's just about Chinese people. Like just say what it is, you know, just name who you're including. And that's actually guidance, other guidance that our groups have given us is that, you know, it's a slash between Asian American, or there's an ampersand between Asian American and Native Hawaiian and Pacific Islander. There is a slash between Native Hawaiian and Pacific Islander because they're distinct communities. And also that there was one other guidance that they don't want Asian American, they don't want AAPI community. They want AA and NH/PI communities to distinguish the fact that we are actually distinct communities. But again, like throughout COVID, I've had like wonderful relationships with working with our Native Hawaiian and Pacific Islander partners, but it's always about sovereignty. Like you have to respect their sovereignty. You have to respect what data do you actually have in front of you? What data do you have in front of you to be able to write your article? So I completely agree with Kakoa.
That's wonderful. Yeah. Well, go ahead.
I just wanted to agree with your statement, though, the underlying question being, what is, if we were to aggregate NHPI, which is an inherently small group, who do we technically are able to aggregate with? And the research that I've done personally, as well as the research that I've seen come out pretty recently in terms of, you know, whether or not that it's a Lancet paper with, you know, life expectancy and others, I truly do believe as Indigenous people, we actually have the same sorts of social determinants, health issues, and, you know, issues with colonization. We are not the immigrant story. Even talking about today in terms of, you know, the English language sort of things, especially for Pacific Islanders, Native Hawaiians in particular, you know, we don't have any of those barriers yet. We do have these really terrible, you know, COVID disparities, for example, like Dr. Pan had said. And so I really do think that there's some value into not only putting the Indigenous groups together because they're Indigenous, but also, you know, it combats some of that pushback in terms of, you know, not having enough data, and so they're just going to exclude us anyway. And a lot of my research is actually looking into what are the optimal aggregations, because I think aggregation is fine. I think it just has to be smartly aggregated, intentionally aggregated, in order to really show this underlying theme of what the data is trying to represent.
Thank you. I want to go back to the issue of stereotypes. you in your some of your papers you discussed so eloquently, Dr. Yee, the model minority, the perpetual foreigner. I'll leave out the healthy immigrant because we're in a pandemic. Nobody's healthy. But how do you think? I mean, what I just want to ask, any of you can respond, what the outlook is. Did the pandemic set us back in terms of entrenching these stereotypes and these ideas that, you know, Asian populations are healthier and don't have these problems and don't deserve the funding or the research?
I think a lot of, I can go first. I think a lot of people have awoken to the fact that the model minority is a myth and not an actual fact. I feel like there was a lot of like self-ascribing of that stereotype of Asian Americans themselves. So I do think that there has been progress in that sense of like, oh, actually that's really harmful. Oh, actually it's like a tool that was meant to harm Black people. We shouldn't be self-ascribing that anymore. The healthy immigrant effect is not on the radar. Like, I don't know if it's because this is like more of a health issue rather than like an everything issue. But it is that one. I don't think anyone has any kind of knowledge of. I think the perpetual foreigner stereotype has only gotten worse. So I think that there's a little bit, it depends on what you're talking about and who you're talking about, but I think some improvements, some things that are worse, more challenging.
Let me ask you, Monica, what are you seeing on the ground in those communities? I know there's been a lot of discussion about mental health, and are there other, how is the pandemic sort of either entrenching or highlighting problems that we need to address?
Yeah, I would definitely agree with Dr. Yee. I think in the sense that perpetual foreigner, the myth has definitely gotten worse. I think, yeah, as mentioned, you know, just with the racial uprisings of 2020, as well as pandemic and the anti-Asian violence and hate that's really sprung up. I think many of our communities are having to talk to each other about what safety looks like, and hopefully what safety looks like without more policing, because we know that does harm other communities. So how can we continue to be in solidarity? I think with other communities, especially the African American and Latino, Latinx communities. But I think, yeah, I think mostly too what Dr. Yee was saying, I know we've seen food insecurity as well. So I think that's definitely poked holes in either internalized model minority or external model minority myths about just what people are struggling with, you know, the typical issues with inflation and what everybody's facing right now.
And, you know, Dr. Pan, you brought up the issue of language and that being just as difficult. And then there's the issue of being splintered into many, many smaller groups, you know, which is related. Do you feel one is more challenging to address than the other, or do they go hand in hand?
Well, I think, you know, one of the challenges that we have is how do we come together? As I said, we are not Asian until we come to the United States, right? And you know, in terms of the Asian American, and so how do we work together? And meanwhile, there are people trying to drive us apart. So as I said, whether we talk about issues like affirmative action, we talk about other types of issues as well. Policing. I mean, let's put it this way, you know, because after all, I mean, I'm an elected official, so there is pressure within the, you know, the AAP, the Asian American community, at least, for more policing, right? So our caucus strategically decided to not emphasize policing, but we had tremendous pressure to increase, to say, hey, how come you're not putting more money into policing? You know, you got us all this money, but we need more law enforcement, right? To protect our community. So those are issues. I would point out that in terms of, you know, you talked about the model minority myth and the perpetual foreigner. You know, we're in this sort of hyper-partisan era, and we're also in this era where basically, and I'm going to, you know, it's point out, you know, social media has been a fabulous tool. We invested billions of dollars in making sure it works really well in dividing us. Okay. And so that tool has been used, you know, maybe not what that may not be the intention of the inventors or the people, et cetera, but there are people out there, both foreign and domestic, who are using that tool to drive divisions and of course play off on the stereotypes. And I think that, I think Dr. Yi, I think you pointed out toward the conclusion of your presentation, right? It's people have preconceived notions, and they like to, if they see things that reinforce that, that works. And if it doesn't, then they're like, oh, well, that doesn't make sense to me, right? And so, I would say that the spike in Asian hate, it certainly, on one hand, first of all, it's a horrible event, so I'm not suggesting it. It did help raise issues, and for the larger community, that's why we were able to get the funding we were able to get through the state budget. But at the same time, unfortunately, there are others out there who actually are continuing to ramp up hate against our community. Not only leaders using words like China virus, Wuhan flu, Kung flu, etc., but also the efforts to also, but I think also, for example, with China being sort of one of our main rivals, right? The People's Republic of China, then using that's becoming an issue in terms of generating hate against Asian Americans. As I said, they don't quite distinguish between whether you're Chinese or Korean or Japanese, at least, right? And Vietnamese or whatever. So that drives more hate. And I think it's going to be important for journalists, right, to have to dig into that. So, and then of course, the other thing I should point out is, like, for example, the China initiative, right? And so you have the FBI going after scientists who immigrated from China, and just because they are still in contact with families in the mainland, suddenly now they're traitors, right? And they're being falsely prosecuted. I mean, these types of stories have to be very carefully reported on, and not just simply take the authorities' words at face value and report them, because that will continue to perpetuate the forever foreigner, including not only foreigner but also essentially someone who's disloyal to America. So let's not repeat the mistakes we made back in World War II when we got Japanese Americans incarcerated while their sons went off to fight in some of the bravest battles on behalf of our country. Let's not have that happen again.
I want to ask you, Dr. Yi, when you talk about your work with food distribution and Asian, and that list of organizations you work with was, it was beautiful. It's like the United Nations, but working with, and you mentioned Hispanic families, and it just strikes me that that's so unusual to see those groupings that so much, and maybe Ms. Lee can join in too, is our work at the community level kind of also splintered, or is that the place where these seeds and bridges might occur?
Oh yeah, I'll give you two examples. So I think on the boots on the ground, not even boots on the ground, from the boots on the ground and up, I actually think boots on the ground is less splintered than academia. Everything in academia is about race, ethnicity. Nothing is about oh, what is our shared experience across X? What is the shared experience across this? And so one of the things that our group has been trying to promote is this idea of some of the commonalities, using published literature to actually, back up our claims. What are some of the commonalities between different immigrant families where you can be efficient in leveraging those commonalities, like the importance of family or the importance of family meals or meal preparation together. You can leverage those kinds of things to create a base of programming, but then you can respect and celebrate the uniqueness of each culture by bringing in a lot of cultural diversity, hiring staff that actually are from those communities to help you, partnering with organizations that actually serve those communities. So, but that is not the norm. I would say that the majority, I actually feel terrible, because when I think about the disaggregation problem in the Latina community, in the research world, in the health research world, there is no attention paid to it. I would say it's 1% of the story. And if you pull 50 articles on the Latinx community, you cannot figure out what ethnicity they are. So anyway, I think there's a lot of work that could be done in terms of harmony, thinking about how our groups are similar. We have the same experience with our data disaggregation work. In fact, we work in very close partnership with the Arab American community because their story is slightly different. right? Like Asian Americans, like we don't have the data disaggregation. Asian Americans are lumped together with NH and PI, and it's completely a big mess, right? But Arab Americans are literally invisible. Like they're not even, you can't even make anything. There's different challenges that come with that, right? But one of the things that we're doing is that we're sort of like hitching them on our train. Like in Illinois, for example, there's a lot of Arab American work, there's a lot of Arab American advocacy, and it's the opposite. Like the Asian Americans are like going onto their train. Whereas like in New York, because this Asian American data disaggregation, Asian American and Pacific Islander data disaggregation is happening at the state level, we've been able to sort of bring our Arab American colleagues along. And so there's a lot of opportunity to do that at all levels. But I would actually say the people that I see on the ground, like the community partners we meet, they're like, oh yeah, half our clients are Mandarin speaking, 30% of them are Ecuadorian and maybe 20% are actually Mexican. And they serve all of them. And all those people are in the same rooms together. So they get it, they're on the ground. It's the people in the ivory towers that don't get that. And then everything becomes like completely splintered. So I'll pause there in case Monica has anything to add.
No, I would completely agree. I think thankfully our community partners don't see it as a zero-sum game. They really are coming together collaboratively, especially during the pandemic, to address really the needs that they were seeing, and like coming together and applying for grants and using their power and their resources to work together and work collaboratively. Yeah, so I would say, yeah, thankfully, again, yeah, on the ground level, there is definitely more cross-cultural and cross-racial solidarity and working together.
Beautiful. Well, thank you so much. We're at time, and I promised Dr. Yee we'd end on time because it's very late in New York. I'm actually on East Coast time from a recent trip I just took. So I appreciate the speakers very much. This has been such an incredible conversation. Thank you for the people who joined us. We will make sure this gets posted to all of our sister chapters. So we have to thank AAJA Los Angeles, San Diego, Sacramento, and San Francisco. We really appreciate your being here and being part of the conversation. I think we probably have to have a part 2 because I feel like we just started going on these really important issues that are really evolving very quickly. And yes, we will make sure to send out the recording to everybody on the Eventbrite, or you can reach out to me and I'll post it on Twitter as well. I'll make sure all the speakers have it as well to get, to circulate to their networks. If you have any questions, you can contact AAJA-LA. But thank you all. I really appreciate you being here.
Bye. Thank you for organizing this. This is wonderful. Thank you, everyone.
Thank you. And thank you, Dr. Pan. Thank you, Dr. Tapara. Thank you, Ms. Lee. Bye.
Thank you.
Bye, thank you.